Assalamu alaikum. The long clinical consultation day. The first scenario, Mr. John Adam, 35 years old, presented with bloody diarrhea and jaundice. Please take history, examine the patient, and address his concerns. Ready, Dr. Maida?
Yes, I'm ready.
Okay, here you go.
Okay. Hello, welcome. My name is Dr. Maida, one of the medical doctor. Can I confirm your name? Can I confirm that you are Mr. Adam, 35 years old?
Yes, doctor.
Okay. Mr. Adam, I understand that you come to the hospital with some loose stool. Do you want to tell me more?
Yes, doctor, I have this loose motion since 6 months, and later it become more frequent and has blood. That's why I come here today.
I'm so sorry to hear about it. So you have this loose motion for the last 6 months, increasing in the frequency recently.
Yes.
For how long the frequency has been increased?
It was about 2 to 4 times a day, and now it's reaching 6 times a day.
6 times a day. And how you cope with that? Do you drink a lot of water?
I'm trying.
Okay. Is it just loose stool or it's contain any blood?
Yes, it's containing blood.
Okay. And is it mixed with the mucus or the color or there is any change in the color?
I didn't notice.
Is it bright blood? I mean, is it bright blood, red blood, or it is dark blood? I mean,
It's red.
black.
Red blood.
Red blood. Okay. And I understand also you have this discoloration of your skin. Can you tell me more what's happened since when you have this discoloration?
It's 2 months now, and I have this yellow eyes I noticed in the mirror. And people say also my skin become yellow.
Is it increasing?
Yes, I think it's increasing.
Okay. What about your water work? If there is any change in the water work at all?
It's I think it's darker.
And what about your stool?
It's I didn't notice much change.
Okay. And can you tell me, do you have, apart from that, there is any tummy pain at all?
Yes, I have this tummy pain.
Can you tell me when exactly? Why exactly?
In the right hypochondria.
In the right hypochondria. Okay. How it looks like? Can describe this pain for me.
It's like dull aching pain.
Dull aching pain. If I give you a grade of pain from 0 to 10, how you can grade the pain?
5 to 6.
5 to 6. It sounds a little bit painful. Do you take any medication for it?
No, I didn't take.
Do you know if anything can relieve the pain at all?
No.
Okay, Mr. Adam, can you tell me, do you have any change? Do you have any temperature, high temperature?
Yes, doctor. I think it's 38 or more sometimes.
Okay, sometimes. Okay, since when you notice that you have this high temperature?
In the last 2 months.
In the last 2 months. Is it associated with any rigors or shivering?
No.
Okay, any weight changes?
I think I lost weight.
How much?
Maybe over the last 6 months, about 5 kg.
5 kg. What about your appetite?
It's I think it's reduced.
Okay. Okay. If there is any, do you feel fatigue?
Yes, I feel tired.
Okay. And any short of breath at all?
No.
Mm-hmm. Do you have any itching?
Yes, I have itching.
Mm-hmm. Okay. Do you have any urge to go to the toilet?
No,
Mm. Do you vomit? I mean,
no,
thrown up. Do,
no,
do you ever been sick?
no,
Okay. Do you feel dry mouth?
no,
Any dizziness?
no.
Okay. Okay. Apart from that, just I want to walk quickly uh, about your background. Do you have any history of what we call inflammatory bowel disease? Do you ever been diagnosed before by this?
I didn't seek a medical advice before, doctor. It's my first time here.
Okay. Do you have any illness you should be aware of?
Nothing.
Mm-hmm. Okay. Uh, uh, just I want to have a quick look about in your medication list. Do you have any medication list?
No, only painkillers for any headache I have, like,
Okay. Do you have any recent antibiotic?
no,
Okay. Uh, can you tell me, do you take, sorry to ask this question, do you take any illicit medication?
no, I don't.
Hmm. I, do you have any history of travel? Do you travel anywhere?
No, doctor, I did travel recently.
Not recently. Okay. Do you, about your normal habits at home, do you consume undercooked food?
Sorry?
I mean, do you consume like undercooked food? Do you use
No,
food undercooked? Okay,
no,
okay. What about shellfish? Are you eating shellfish?
no,
Okay. Do you have any recent contact with an ill patient?
no.
Mhm. Okay. I also want to ask you if that's okay. Uh, can you tell me if you are married?
If I what?
Married.
Yes, I'm married.
Okay. Do you have any extramarital relationship? Sorry,
No, doctor.
there are very personal questions I've been asking. Sorry.
Okay, no problem. I don't have.
Okay. I also just want to check about your family. Do you have any family history of the liver disease at all, as far as you know?
No.
Mm-hmm. Do you have any
Family
something
planning.
to remain? How is that? Do you have any do you have any family issue? I mean, do you have any uh, something running in the family? Any illness
No,
running in the
no.
family? Okay. Okay. I will examine you, and while examining you, I can complete my history. That's okay.
Yes, yes, it's okay.
Okay, so I will start by general examination of the patient. I need the vital signs. If there is, especially for the fever, tachycardia, and
The
hypotension.
temperature is 38. Blood pressure is okay. Yes, there is anemia. White blood cells are high, more than 10.
Mhm. Also, I'll have a look for hydration status. That's by looking for the tongue and the looking for the tongue, armpit, if there is any sign of dehydration.
No.
Okay. I have general look. Then I will ask the patient to look for a sign of chronic liver disease, by colonekia, and I will look if there is any debutrient contraction as well, and then I will look for the pulse. If it's high volume pulse or low volume pulse, then I will look for if there for fistula. Then I will look for temporalis muscle if there is any temporal waste.
No, nothing.
Okay, I will say all the things and then you just tell me the positive one.
Yes.
Look for the eye for the jaundice and for pallor
Yes.
as well.
So there is jaundice, there is pallor.
Okay, then I will go down to the chest. I will expose the chest for, I will ask permission from the patient. I will expose the chest and the back, looking for spider nevi and the gynecomastia.
Nothing.
Nothing. Then I will go down to examine the abdomen and for first by general look if there is any scratch mark, if there is any obvious mass. There is a scratch mark, and then I will examine for the liver and the spleen size.
There is tenderness over the liver.
There is tenderness over the liver, and if there is any hepatomegaly.
No, not detected.
Okay, I will do the liver span.
No need.
Okay, then I will examine the spleen for splenomegaly.
No, no splenomegaly.
Okay, then I will percuss for ascites if there is any ascites. Okay, if there is any, sorry.
Complete your palpation, the 9 areas.
Okay. Okay, I will percuss for the 9 areas. If there is any tenderness anywhere.
Okay, with superficial palpation, you can find like a mass in the left iliac fossa.
Left?
Yes.
Okay, then I will ensure that is it a spleen or that I cannot go above it, moving with respiration. Sorry?
It's left iliac fossa, not spleen.
In the first iliac fossa, okay.
Left iliac.
Okay, left iliac fossa. I will. Is it palatable? I mean, is it kidney? Okay, it's just mass.
It's color.
Okay, I will look for the mass, the size of the mass. Is it moving with not moving with respiration? You said, and is it the kidney? In the area of the kidney? Okay, in the colorectal area. Then there is no ascites. I will offer to examine the pack passages.
Need.
No need.
2 minutes left.
Then I will examine the lower limbs.
Nothing in the lower limbs.
Okay. Okay. Just want to ask you, do you drink alcohol?
Only occasionally.
Occasionally. And what do you do for a living?
I'm a teacher.
And, how this affect in your day-to-day life?
It's become very embarrassing when this increase the frequency. I have to go to the bathroom. It's fine.
Okay. Yeah, I can understand that. Mr. Adam, can you tell me what's your concern?
What's wrong with me, doctor? Do I have a cancer?
Mm-hmm. I highly appreciate that. I know this is at the moment, cancer is one of our differential. Still, we can't roll out the cancer, but still we need to run some investigations, including blood tests and imaging to make sure. At the moment, I want to admit you to the hospital to make sure that you are we are giving the hydration. You are well hydrated, and at the same time, we need to monitor your blood so to make sure that you are not anemic as well. So we will treat you under a MDT. That means multiple doctors will come to see you. This including mainly under the medical team and the gastro team. This is the gut team. And also we will ask our nurse and occupational therapist to assist you during this period of time. Does that sound okay?
Yes, it's okay, doctor.
Okay.
Is it treatable?
As I told you, at the moment we didn't reach the bottom of the diagnosis, and after we have sure about the diagnosis, I will arrange another meeting with you, and because there is a lot of a lot of differential around the corner. I don't want you to give you one diagnosis until we do the investigation completely. But as I told you, I can't reassuring you that there is no cancer. The cancer, one of the possibility. So after that, we'll arrange another meeting to give you the diagnosis and how we will go further after that. Is that okay?
Yes, it's okay.
Okay, time is up. Examiner questions.
Okay, what is your positive finding in that case?
Okay, so this gentleman, he's the 35 years old gentleman, presented with a long history of over 6 months of loose motion with bloody diarrhea, and 2 months history of jaundice and weight loss with fever, with no positive history of travel or family history of notes. The positive finding on examination of this gentleman, there is no sign of chronic liver disease, but apart from itching, indicating of most probably obstructive type of jaundice. He has mass in the left iliac fossa. This mass is still for investigation. Most probably maybe a cancer, maybe malignancy.
In this patient, 35-year-old, do you think that he has cancer?
It's still a possibility, but there is another differential diagnosis with it's right iliac, yeah? Right, or
what is
left?
what left
Right.
iliac fossa? What is your first differential in that patient?
Okay, so
He has bloody diarrhea. What is your differential for a bloody diarrhea?
Bloody diarrhea, I'm thinking first about IBD, mainly ulcerative colitis or and Crohn's disease. It can be Crohn's as well in this age group.
Are you sure it's a
this
Crohn's?
is the
Did you
first-
find a mouth source?
Yeah, I need to examine the mouth for ulcers.
You only asked about dry mouth.
Mm.
Okay. How will you manage this patient if he is ulcerative colitis?
If this, okay, I'm starting by investigation to confirm the diagnosis. I started by bedside investigation for this gentleman. I will ask for this gentleman. I still need to ask about ECG for as bedside test. He has bloody diarrhea for 6 months. I will be worried about he's having anemia, so I will ask about the lab investigation, including CBC, full blood count, looking for sign of iron deficiency anemia and anemia of chronic disease as well, with this massive bleeding. Sorry?
Specific test.
A specific test for I will do liver function and kidney function, definitely. A specific test, I need to do a colonoscopy. This is and
what will you find in colonoscopy?
I'm not quite sure. I'm not quite sure about the finding the colonoscopy.
What do you think this patient has jaundice after he has ulcerative colitis? What is the cause of jaundice in that patient?
Cholangitis as a part can be associated with ulcerative colitis or apart from autoimmune disease. It can be having cholangitis.
You mean autoimmune hepatitis?
Primary cholangitis.
Primary sclerosing cholangitis.
Primary sclerosing cholangitis. It sounds to me obstructive type of jaundice, giving the itching and pale stool. He didn't mention the pale stool, but the dark stool.
Okay.
Okay.
And if you give that patient, he's in acute attack now, what you're going to give him now?
Admitting the patient, supply the patient, and then I will give him steroids treatment for him. I will do urgent CT scan looking for enlarged colon, and I will discuss with the MDT, the gastro team.
Okay. Do you think any other thing you need to do in that patient?
Yeah, fecal caloprotein.
Protected. Okay.
And I need stool charting for this patient.
How you will diagnose the primary sclerosing cholangitis?
MRCP.
Okay.
First MRCP and then ERCP.
Okay. Time is up, I think, Dr. Bassem.
Yeah, perfect, Dr. Azza. Very nice questions to that point. And
I'm sorry, I was very rude. So sorry.
No. The way you are asking, like you are examiner, really. And the way waiting for the answer, the switching to the other question, the way like perfect and professional question and examiner.
Sorry.
No worries. Okay, your comment, Dr. Azza, then I will comment.
Okay. I'm sorry, I don't know the name of the doctor.
Dr. Maida.
Dr. Maida. Okay, Dr. Maida. Okay. First, you said many jargons. Okay. Too many jargons. Okay. And you weren't systematic at all. First, you have to analyze the bloody diarrhea, and then you have to analyze the jaundice. Okay. You asked only a few questions for the diarrhea. I told you I have it 6 months and it become more frequent. Okay. You should ask about the amount. The amount will give you an idea about if it's ulcerative or Crohn's. Crohn's affects the small intestine, so it would be a very large amount. Okay. You will have, but for ulcerative colitis, it affects the colon, so it would be very small amount. Okay. You didn't ask about the amount at all. You didn't ask about the consistency. You didn't ask if it's loose, if it's semi-solid. Okay. You didn't ask about the odor. You didn't ask if it wakes up you at night. Okay, to exclude other causes like IBS and something happened to the screen. Dr. Bassem, are you hearing me? Hello?
Yes, Dr. Azza, carry on. Yes, we can hear you. Yes.
I thought I have something in the net.
No. We can hear you. Carry on.
Okay. And you didn't ask about if it's related to specific time of the day. Okay. You didn't ask if it's related to specific type of food. You didn't ask if he is eating a balanced diet. Okay, you asked about the decompensation symptoms, only about drinking more water or eating, but you didn't ask about if he has hypokalemic symptoms like cramps in his legs. Okay, and the dizziness, for example. Okay, and you didn't do any systematic review for other systems. You only asked about GIT symptoms. You didn't ask about mouth sores. You didn't ask about chest burning or acid taste. You didn't ask about anything related to CNS, CVS, chest, nothing at all. You didn't ask about only 2 questions for each system. I know it's not related in that case, but you need to ask systematic, okay? And what else? Yes, for the jaundice, you only ask 2 questions for the jaundice. You need to ask everything. I told you it's 2 months, okay? You didn't ask how it starts. Is it sudden or gradual? Okay, because in obstructive jaundice, usually it become more dense all the time. Okay, so it's a progressive. You didn't ask about I think I write here. Yeah, you asked about HIV risk and travel history. That is good to exclude infectious causes. You asked about past medical history, family history. Okay. You need to ask a few questions about vitamin deficiencies. Not in that case, but in GIT cases like in celiac, for example, you will have like he will tell you that he has a bone pain, for example, like vitamin D deficiency. He can ask if there is bruises in his skin, vitamin K deficiency. Okay, only one question for each. And what else I write here? You ask about the previous antibiotic intake. This is very good. It's a very important question in diarrhea. You asked about weight changes. I told you 5 over 6 months. 5 kg is not a big weight loss. It's not a red flag. I know that question made you think about cancer, but in ulcerative colitis, you can feel some mass in the colorectal area, and in Crohn's, you can feel a mass in the ileocecal area. Okay, right, ileofossa. I don't know if I forget something, Dr. Bassem, just remind me.
Yeah, the tattoo and piercing again for
Yeah,
infection.
for HIV. She asked about sex history only.
Yes, exactly.
Yeah, and the travel history. Okay.
Yeah.
I tried not to make it difficult case. It's ulcerative colitis complicated with primary sclerosing cholangitis. And I had many questions for the examiners, but I asked only a few. Okay.
Yeah.
It's
Yes.
okay, we can discuss. Okay, for the colonoscopy, in ulcerative colitis, you will find widespread ulceration with preservation of
Yes.
adjacent mucosa. It's a pseudo polyp, okay?
Mhm.
In Crohn's, it's a deep ulcers and
Yes.
capillary appearance. Okay. That is, yeah, for the admission, yeah, you make it nice when you say it's admission. Yes, you should admit the patient. And first line, he has in his colorectal, so you need to give him rectal salicylic, okay, with steroid. Intravenous steroid, second line oral prednisolone, okay. What else? Okay. Investigations, you need to make it very simple. Especially, you have to cover rule of Witts criteria in IBD, okay? So you have to know everything about it. Okay, Dr. Bassem, we can discuss that rule of Witts criteria, or should we proceed and make it at the last?
No, it's okay. Try to finish the comment, and I will comment in general about that whole topic after your
Yeah.
comment.
You
Continue.
only commented on dilated colon, megacolon. Yes, it's very important ulcerative colitis patient. Yeah. Okay. And it should be more than 6 centimeters to diagnose. For rule of the criteria, more than 6 bloody diarrhea per day, temperature more than 37.8, heart rate more than 90 beats per minute, ESR more than 30 millimeters per hour, CRP more than 30 milligram per liter, HP less than 10.5 gram per deciliter, neutrophil more than 10, and dilated core more than 6, and radiological finding, loss of castration. Okay, that's the rule of the criteria.
Leukocytic count?
Yes, I said neutrophil more than 10.
Okay, you mentioned,
Yeah.
okay.
Yeah. Okay. And the risk factors for megacolon, hypokalemia, hypomagnesemia, under treatment, non-steroidal anti-inflammatories, opioids, analgesics, anticholinergic drugs, antidiarrheal agents. So be careful if you prescribe antidiarrheal agent for IBD patient, because it will precipitate for toxic megacolon. Okay. Okay, and yes, you should mention surgical colectomy. You may need to add a surgical in your management plan. Okay. I think that's all I have, Dr. Bassem. I don't know if I missed something.
Perfect, Dr. Azza. Nice performance about the topic itself. My comment to Dr. Maida, she did well, she reached the diagnosis, but again, she missed some points or a lot of points. So let's repeat it as teaching way in my approach and try to see what we can miss if we start in this way, Dr. Maida, okay? So after analysis of the complaint, as Dr. Azza said, you will start the diarrhea. I already shared to the chat box the most important question in diarrhea patient. And please, at least ask these 4 questions, plus onset course duration. I made video for the diarrhea approach. I think if you cover these questions, you will, yes, you reach to the diagnosis, but you have to rule out other causes. Because you didn't mention the question for the ulcerative colitis. For example, awaking you from sleep. It's a very important question. And in such type of diarrhea, the patient will have awakening from sleep for diarrhea. Related to type of food, you didn't ask this question, which is also important to rule out celiac, although it's not here, but the examiner might ask you, did you ask this? So it will minus you in the approach, either the clinical communication or the differential, because you have to put differential in this patient. The third question, is it flushable? And again, it's either celiac or short bowel with Crohn's disease or some steatodiarrhea causes. Steatorrhea causes malabsorptive diarrhea. Ulcerative colitis is not one of these causes, but we have again to ask this question to rule out malabsorptive causes. And the first question I already mentioned, the flushability, the blood. The blood here is very important. So you roll in the cancer and the ulcerative colitis or inflammatory bowel disease. The amount, the consistency, okay, I agree. And you have to ask about previous attack. Is it previous, is it first time or it has happened before? It's important to know, is it chronic or it is on and off or just started as acute diarrhea? This is as analysis of diarrhea. The second complaint analysis, jaundice. You analyze it well, but from jaundice itself, you can ask related question to the jaundice, and you ask it later. I prefer to ask it in the same time of analysis of the diarrhea, of the jaundice. The itching is very important. You have jaundice, so you have high bilirubin, so you might have itching. Better to ask this question after the jaundice itself analysis. I prefer to do that. Then we will do the relevant system question. As Dr. Azza said, the mouth started from the mouth. You will ask about mouth sores to roll out or to roll in Crohn's disease or celiac. Ulcerative colitis, it will not have the mouth sores. This is the first question in the GI from the mouth, right? Downward, difficult of swallowing, more down, any abdominal discomfort or tummy discomfort, more question in the tummy, any fullness, discomfort, tummy pain. Of course, there is tummy pain. You analyze it and you ask about the severity, which is good, the area, the site, and where it goes. You have to ask where this pain goes. You offer painkiller, which is good. Any change of the bowel habit, this is our case, so it's diarrhea. But you can ask any alternative bowel habit like constipation. Again, this is for irritable bowel syndrome, which is not the case, but the patient is having always diarrhea. Then the blood itself, you ask about the color, the content. Is it dark? Is it pale? Is it fresh blood? All these questions will be related to the GI questions. Finish the relevant system. Now the constitutional symptoms. You ask and you have found positive finding of loss of weight, loss of appetite. So you have 2 alarming symptoms. You put cancer, one of the possibility, as you said, plus inflammatory bowel disease. Lumps or bumps, fever, night sweats, all this question also for the same constitutional symptoms. The systemic review now. Please, when you start systemic review, start from the head down to the toes. From the head, CNS, any headache, This patient might have headache because of anemia, because he has, yes, a lot of blood loss. Then you can ask about peripheral sensation affection, pins and needles, and it might happen also as malabsorptive diarrhea. And the next questions for we already finished the CNS. You can ask also about unsteadiness. Yeah, the unsteadiness here is important again for the vitamin deficiency. For the balance itself, vitamin B12 deficiency or even anemia itself might cause dizziness. You can ask the dizziness also in this case. This is regarding the CNS. Any other preferences? Quick system review question. Chest pain. You didn't ask about chest pain at all. This patient is having anemia. He might have ischemic heart disease or anemic heart disease because of anemia, especially if the anemia is severe. Chest pain or awareness of heartbeat. Definitely, this patient will have awareness of heartbeat, particularly if the hemoglobin less than 7, for example, or maybe 9 in this age. Short of breath, it might be also there because of anemia again. Cough, you can ask the cough if you suspect HIV, for example, or serious infection. And the next system, already GI asked and analyzed well during the analysis of the complaint. The genitourinary is very important about the amount of urine, the water work. With severe diarrhea and frequent diarrhea, the patient might have anuria or oliguria, and it changes color of the urine. It would be dark. In this scenario, what do you think, Dr. Maida, the color of the urine? Dr. Maida, this question for you. Particularly, the color of the urine in this scenario.
She
What
said
might
that
be?
color. She said, doctor.
It's
Yeah, I
dark,
know.
dark, dark.
Exactly. You ask, right? Okay. Because of what? The same question, the same, yeah, obstructive jaundice. Okay, this is for the genitourinary. The next system, the musculoskeletal, which already missed totally by you, any skin rash, any joint pain, and it's very important in this scenario. You might have a lot of these finding, either skin rash or joint pain as extra intestinal manifestation. Particularly with the inflammatory bowel disease, you have to ask this question, either Crohn's or ulcerative colitis. By the way, we missed the eye. It might be also associated with the vision problem or redness of the eye. It might be also there. Then the family history, I prefer to ask about cancer itself, any history of cancer. Because you will have this question at the concern, definitely he will ask you, doctor, do I have cancer? Yes, you ask any family history if not, but particular question for the cancer is a must. This patient might have cancer colon as a history, and it would give you strong possibility to be a cancer in this scenario. So family history of note or family history of cancer or family history of gut disease is very important. The travel history, it will come in the social, and it's if positive, you will suspect infectious causes of diarrhea. The HIV, you have any partner, any casual relationships. Sorry for this question, to roll out or to roll in HIV. Continue asking other cause of HIV, like tattooing, piercing, blood transfusion, or procedure or surgery. It's important. Earlier, you asked about past medical history, which is good. Any past medical history, he deny anything. You have to ask about any surgery, any allergy, because you are going to give him some medication, any history of infection and antibiotics. You ask this question, makes sense also. Do you smoke? Do you drink alcohol? The job, the affection of symptoms on his job, and the examination. The examination, I think you cover the steps of examination, general examination, the hand examination for anemia or cholonicia, leukonychia, clubbing, important to rule out clubbing here. And you have to ask about also the pulse character and the dehydration signs in the hand, as well as in the mouth, dry mucous membranes. The jaundice already you examined. Spider nevi in the chest and in the back. all questions for chronic liver disease. Then the abdominal examination, as Dr. Azza said, don't forget to inspect for any scar. It's important. This patient might have a previous scar, either by history or by examination. The leg examination, it will be at the end to rule out any edema or dehydration sign again. I think Dr. Azza covered the topic of inflammatory bowel disease, how to
Sorry,
investigate.
Dr. Bassem,
Yes.
the leg will also receive manidosum and pachyderma
Perfect.
gangrenosum.
Yeah, perfect. This is by examination. And by the history, she will ask about any skin rash. You might give her this history, either bioderma gangrenosum for ulcerative colitis or erythema nodosum for Crohn's. But it's not necessary to be for each type. So you might have this in that, and you might have this that in the Crohn's. So it might be happen as the opposite. The differential here, inflammatory on the top, the colon, cancer colon as well, second differential, and you have to put primary sclerosing cholangitis as association. It's very important. This patient has ulcerative colitis, he might have the primary sclerosing cholangitis as a complication or association. The diet, if you want Dr. Maida to ask about the diet, just ask him, how's your diet? Is it balanced or no? So it's not necessary to ask undercooked. If you suspect travel history, you can ask this question, because at home, suppose everyone will cook well, but you can ask general question about the diet. How is your diet? Is it balanced diet or no? That's it. Okay.
Um,
This is my comment. If you want to ask or to add anything, Dr. Maida.
yeah, thank you for both for these comments.
Mhm.
But the approach for the diary, I think when I'm asking all these questions that I'm thinking about IBD and everything, but I have clue that this patient have bloody diarrhea. So my differential diagnosis is only about the IBS and irritable bowel, IBD
Inflammatory one. Yeah.
and cancer. So I will go
Okay.
through this tract. The questions of the general question for diarrhea, if I have diarrhea with no blood, so I need to find out which type of it. That I go through all these questions.
Okay, I agree with
Maida,
you.
HIV is very important in bloody diarrhea.
Yeah, it's okay. So what I will ask about it's one of the differential. So
Yeah.
the differential diagnosis, I already have the clue that what type of diarrhea it is. It is bloody diarrhea. Then I will go through the tract, not asking about other questions. Is it you get what I mean?
Yeah, we got to your point, Dr. Maida, but you don't know the examiner mind. He might tell you our question. Did you ask about the awaken from sleep, for example, just to confirm this is by the history? By the way, you can do the case as target questions, but if like this will not go to the exam. They want us to show them that we are asking about important question uh, in the case. For example, relation to the food, it's important, I guess. It might be celiac, and the celiac complicated with cancer, for example. I agree, for somehow the question should be targeted. But again, our question is not that broad. It's also to the target for the food, for the flushability. It might be also related to malabsorptive diarrhea, along with the bloody diarrhea, right? Crohn's disease, I mean. Anyway, I'm always saying this is my approach. If you are convinced, you can do. If not, you can do whatever you are preferring. But for the optimum, we need to be at the optimum level of taking history for the clinical communication. It's not, I don't assume this is my approach is the optimum, but if you ask questions, for example, the system view in this scenario, You have to ask all system review, right? Pins and needles. What's the importance of pins and needles? Yeah.
The systemic, I totally agree with you that systemic review is quite important in this case to find out the complication. So
Exactly.
maybe my approach is a little bit different. Like I will start with the diarrhea itself. I know that it is type of diarrhea, that it's a bloody diarrhea. So I will go through the tract of bloody diarrhea, the differential diagnosis of what is the bloody diarrhea, then what's the complication in this specific patient. I'm trying to find the complication through examination or all the finding. Maybe I didn't approach through this history, but still I can find the complication through the examination, which I think I will add to what I did wrong, that I need to examine at least listen to the bibasal crackles. Maybe this is patient in heart failure with this blood problem. So this patient complication can come from his anemia, can come from his diarrhea, and with the malabsorption things, and he may have complication of Crohn's disease by itself. So this is important to at least check in the examination as well.
Okay. Thank you, Dr. Maida. I got your point. So it depends on your experience. So if you are confident with what you are doing practically and in the exam, so do it. But I prefer to show the examiner that you are rolling out other possibilities. This patient might tell you at the end, my mother was having celiac. Do you think, doctor, this is celiac disease? So you can have an answer by saying, yeah, it's not related for certain type of food, for example. So it would convince the patient concern. That's why some questions, yeah, it's not related, but it will give you a clear answer to the surrogate, and you will address the concern by this answer. And of course, you might have the answer from your history taking, not from the examination. Okay? But be ready for any question from the surrogate. He might tell you, as Dr. Azza said, is it a cancer? Which is one of the possibility. I prefer to say possibility rather than saying differential, because maybe differential is some medical term. And try to avoid jargon, as Dr. Azza said. You have some jargons. Otherwise, you did great. By the way, Dr. Azza, Dr. Maida, you reached diagnosis. You confirm the diagnosis. The answers also was to the target. And in general, you can pass this case station. Thank you, Dr. Azza and Dr. Maida, for the performance. Now, the second scenario. Dr. Maida, you can write the scenario for Dr. Azza.
Okay, but Dr. Bassem, one more comments.
Yeah,
Sorry.
we didn't finish. By the way, we didn't close the case. I just asked her to write the scenario, then you prepare yourself. We can have still some time to discuss. So you can say, Dr. Azza. Go ahead. Continue.
Okay. I have one more question. Differential diagnosis for abnormal liver function test in IBZ. Okay. Anyone want to answer, or should I?
I can answer. You can ask me the question and I can answer.
The differential diagnosis of abnormal liver function test in IBD.
Differential diagnosis for
abnormal liver function test in IBD.
The range liver function test.
What you mean that what I will find in the liver function?
No, it's already raised.
Yeah, what are the causes of involvement of the liver with inflammatory bowel disease?
Okay. What will happen? Okay. I will suspect that ALP and GGT will be high in this gentleman because he has cholangitis. And I will suspect this the liver involvement. Also, ALT will be high in this patient in a case of a part of autoimmune. It can be a part of autoimmune involvement, raise ALT and AST as well. Then according to the disease itself, if he has cholangitis, he may have deranged liver function, like not ALT, sorry, INR, if the synthetic function of the liver is affected as well.
Dr. Maida, name the disease.
Or,
Yeah, give us the names of
forget
association.
that case, Dr. Maida. In general, okay? Abnormal liver function test in IBT.
Yeah, give us the names of association or the disease might be there. What you suspect?
Autoimmune.
Perfect.
Yes.
Okay. This is one. Yeah. What other?
And cholangitis.
What type of cholangitis?
What we call not primary cholangitis, sclerosing cholangitis, primary sclerosing cholangitis, and autoimmune liver disease.
Hepatitis.
And
any other causes?
No, I did remember.
If he's taking medications, it could be mesalazine-induced hepatitis or methotrexate-induced hepatitis. Okay. And it could
after he started the treatment.
It could be obstructive jaundice due to gallstone in Crohn's disease. Crohn's disease associated with gallstone formation. Okay.
Yeah, one more.
Okay, and the metabolic associated fatty liver disease. And could be cholangiocarcinoma. Primary sclerosing cholangitis can be.
Yeah.
Cholangiocarcinoma. It will become cholangiocarcinoma.
Or metastatic from cancer colon.
Yeah. Okay, that's all the questions I had. Okay.
Good questions.
Yes.
Thank you for the case.
No problem.
Yeah. Thank you so much, Dr. Azza. Any other comment, Dr. Azza, Dr. Maida, before opening the discussion? And please, Dr. Maida, write down the case.
I sent the case.
Yeah, okay.
So 24 years old gentleman with any name presented with recurrent infection.
Okay, perfect. So now we'll open the discussion. Anyone has comment, suggestion, doubts?
Sorry, recurrent infection? Recurrent what?
Recurrent infection, yes.
What type of infection?
Chest infection. Recurrent chest infection. Recurrent chest infection.
Chest, okay. Recurrent chest infection. Okay.
Okay, I will read the comment if no one.
Excuse me.
Yeah, sure.
Just in the examination of inflammatory bowel disease at the end, just you have to offer that you would like to examine the preanal area.
Yes, perfect.
Just offer it to the examiner during the exam.
Yeah, perfect. Thank you, Dr. Muhammad. She asked this. She offered for digital rectalization, Dr. Maida, and it's important. Any melena or dark stool or patient with passing bloody stool, you have to offer digital rectal examination. Don't forget as well lymph nodes, either axillary or inguinal. Thank you, Dr. Muhammad, for this comment. Back pain, yes, perfect. Back pain, joint pain.
Differential of abnormal liver function in this case?
Oh, Dr. Aisha? Yeah. No. Yes. She said the question in general. What are the association or the liver affection in inflammatory bowel disease? Okay. You want to know them again?
Yes, please. Because I missed it.
Okay, autoimmune hepatitis and primary sclerosing cholangitis, or hepatocellular carcinoma, or cancer colon with metastasis. I think, drug-induced methotrexate as drug-induced. So we have now 4 possibilities.
Yes, thank you.
Okay. The other question or comment, Dr. Muhammad, extra-intestinal manifestation, yes, we mentioned already, in the musculoskeletal particularly. The vision and the eye is very important. We have to mention it. Maybe with the CNS. Hepatocellular, yes, Dr. Muhammad mentioned already, hepatocellular carcinoma or primary sclerosing cholangitis. Thank you, Dr. Azza. It's a very nice case.
It's okay, Dr. Bassem. We are learning here.
Yeah. Thank you so much. Okay, when you are ready, just let me know to start the second scenario. About the recalls today in Egypt, it was also bloody diarrhea. I think it will not go out of what we put as a differential. Bloody diarrhea in the top. Inflammatory bowel disease, cancer colon. You might have add the infectious causes and HIV you can put as well. But you will pick up the diagnosis from the scenario. And what the approach we did, it will not go out of this. Either travel, positive travel history, either family history, either history of inflammatory bowel disease, chronic diarrhea, which is worsening now. Celiac is not commonly associated with the bloody diarrhea. I think these are the most common cause, but the scenario written in the recalls is not clear, just bloody diarrhea. Recreational drugs also one of the important question here. It might be associated with the diarrhea, but it's not bloody diarrhea unless there is associated HIV. But the cocaine, for example, might cause diarrhea. Any question, any suggestion, any missing point? Diarrhea is one of the high yield topic in the exam. You see from the first day in this diet in Egypt, the diarrhea was there. So it will come every diet, every center. It depends on which day, either the first day, second day, third day. It might be repeated first and third day, for example, by different causes. But it will come, definitely it will come. Get ready how to approach the diarrhea. It's very important. Don't forget to start the general investigation for the CBC, as Dr. Maida mentioned, the anemia, and specifically in this scenario, fecal calprotectin. This is a specific investigation. The bedside tests, you can mention blood sugar, you can mention urine dipstick. You can also think about ECG, echo for heart failure, anemia. And the image, you will start with X-ray. Any patient you want to start with image, you have to start with X-ray. You will not start with CT. X-ray itself can help you for the diagnosis. Not the case, but the complication. For example, air under diaphragm. If you do a chest X-ray, you might have an air under diaphragm. It will be related to the case, for example, perforation after toxic megacolon. You might have also X-ray abdomen for toxic megacolon. You will see dilated colon, more than 6 centimeter, as Dr. Azza said. So before mentioning the advanced image, do the simple image. The second sample or the second image you have to do here is the CT abdomen. Of course, you have to do it. And for the
Yes, I think Dr. Bassem here, we shouldn't mention the colonoscopy first
Yeah.
because in the active ulcerative,
Exactly.
they didn't do the colonoscopy. And there is something now called the CT cholangiograph, and it is giving idea. And the inflammatory markers and the calprotectin, all this giving idea about this is the ulcerative. They
Perfect.
exclude the infection first by stool culture and test, then they will start the pulse steroid. And if
Perfect.
dramatic response for the bloody diarrhea, they making this is professional diagnosis. After stabilization of the patient, they booking him for colonoscopy. But no doctor making colonoscopy in active ulcerative because very high risk of perforation.
Perfect. Thank you, Dr. Aisha. It's very important comment. You have to put your differential according to the case presentation. In this scenario, you cannot do colonoscopy. Yes, it's one of the diagnostic, but not in this situation. After stabilizing the patient, he will go or she will go to the elective colonoscopy, looking for the finding of colonoscopy, which already mentioned by Dr. Azza. This is for the advanced or sorry, invasive test. So colonoscopy would be, but not in this situation.
And really, in real life, we should mention in investigation here the stool culture, stool microscopy. It is a must in any case because they
Perfect.
will start high dose steroid, and it is also a lot of differential in bloody diarrhea, other infection. So if we should make sure that no any infection in
Yeah,
anything having, like if you are having any cough, even if you suspect it is cancer, you should exclude also the infection.
perfect. Yes. This is before starting any steroid. Not only in this scenario, by the way.
And it's a simple thing is you should mention in the first. The examiner, I think, you would like to be from
Yeah,
start if
inflammatory
patient have
markers is.
diarrhea.
Mm.
Yes, diarrhea. The first thing you should tell, I'll do stool analysis through microscopy, stool culture.
Stool
Yes.
culture is important in
Yes, you're right.
it's very important in stool culture. I agree, but I think they do sigmoidoscopy in the first 24 hour of the of if they are suspecting, not for the diagnosis, but normally they do sigmoidoscopy in over the first 24 hour in stabilized cases like that. They know that this is
I have
patient
many
is,
cases like that. We never, no one
this is our practical.
will,
Yeah, we will do sigmoidoscopy for the
maybe
first
to
24
exclude
hours.
the surgical causes like anal fissures and ulcers like that, or what?
Maybe
No,
the
no, this is
flexible, not
part
the flexible one, Dr. Aisha.
flexible
Yes,
Yeah,
yes,
the
this is
flexible.
without analgesia, just the lower part of GIT. We can make that if we are having a pain and the local examination suspect that something in the anal region. They doing that for exclusion the surgical causes, that is anal fissures, hemorrhoids, and these things also.
Again,
But
but
it
it's
will not giving any picture that is ulcerative or not,
no, the diagnosis by
because
histopathology,
it is
biopsy
bare,
and
is bare this
histopathology.
side.
no, it's
Yes,
not
Yeah,
it
like
is
that.
usually ulcerative is bare this
skipping lesion. Yeah, skip.
the last, yes, it is doing
Yeah,
also without any anesthesia and no biopsy taking. So maybe it is for exclusion surgical causes if suspected.
but again, it's important to say I have to wait because it's risky for perforation, particularly in the advanced
It
or
should be mentioned really the colonoscopy. It is a definitive diagnosis. This is only definitive test that we will diagnose the condition. But just tell the simple test first and tell that this patient, the definite diagnosis will be the colonoscopy, yes,
yeah,
and
but
biopsy.
perfect. Particularly, if you you're ready, okay, okay, let's start. Here you go. Taz, you can start.
Okay, she gave me the case, okay, but is it male or female?
Male.
Male, okay. Okay.
Okay, assume
Hello,
the same, the patient name, Adam John or John Adam, the same
no
patient name.
problem. Okay. Hello, my name is Dr. Azza Mustafa. I'm one of the doctors in the clinic today. May I confirm that you are Mr. X, 24-year-old?
Yes, my name is Dr. Adam. Yes,
Okay.
Dr. Adam.
Okay, we are here today to discuss your health condition, and I may examine you, and I'll do my best to address your concern. Is that okay with you?
Yes.
Okay, Mr. Adam, can you tell me what brought you to the clinic?
Yes, doctor. Recently, I've become very tired and not myself. And I also have this problem with the infection. I recently have a lot of sick leaves from my work because I feel like tired and infection a lot of time, so I came for that reason.
I'm sorry, what type of infection?
Mostly I have infection throat, like pain in my throat. Sometimes I have infection in my chest. This is most of the infection I had.
And today you have which one?
Today I feel sore throat.
Okay. And in your previous visits, when you took medical advice, what they diagnosed you?
I sometimes I thought medical advice, sometimes I never. So they give me they give me antibiotic and it's help. Sometimes no, and just I go through it. But I think that's a lot of recurrent of these infections.
Okay, and you didn't had any diagnosis before.
No.
Okay. And for now, your sore throat, for how long you have it now?
Now around 10 days, this last sore throat.
Okay. Do you feel that there is any changes in your body temperature?
Yes, I have on and off high temperature, around 39 sometimes. At the moment, it's around 38.
Okay. Is it associated with night sweats?
Yes, I have night sweats as well.
Okay. And you told me that you have the tiredness all the time.
Mm-hmm.
Is it of the same period of your illness?
Yeah, for a long time, yes.
Okay, what do you mean by being tired? Do you mean weakness all over your body or feeling like low mood?
Tired.
Okay, like you are losing power or you can't do your
Yes,
daily
I lose,
activities.
I lose power.
Okay. And for your sore throat, do you have any difficulty swallowing? Is it affecting your swallowing?
Yes, painful swallowing. It will be
Okay.
painful.
Did you notice any mouth sores or rashes, white rashes in your mouth?
Yeah, my mouth soaring sometimes, but not a lot.
Okay. Do you have any acid brush?
Acid rash, no.
No. Okay. Do you have any chest tightness?
Chest tightness. Sometimes when I have this infection, at the moment I didn't have chest not tightness.
Any runny nose?
No,
Nasal crusting?
no,
Nasal stuffiness?
no,
Okay. Do you have any cough?
no,
Okay. Do you have any coughing up blood?
no.
Shortness of breath?
Yes.
Okay. Tell me more about your shortness of breath. Is it all the day or it more specific time of the day?
Most of the time. Most of the day I have this short of breath.
Okay, is it
Mainly with activity.
okay? It's mainly with activity. Okay.
Mm.
Not a specific time of the day, like when you sleep at night, do you use extra pillows?
No, not using more pillows. It's okay, but it's with activity more.
Okay. Do you feel that you wake at night and searching for air, like feel you are gasping for air?
No,
No. Any leg swelling?
no.
Any awareness of your heartbeats?
Yes, I've been aware of my heartbeat recently.
For how long do you have it?
With activity.
Okay, so your shortness of breath and your awareness of your heartbeat, it's only with activity.
Mainly, yeah.
Okay. And they all for the whole period, the 6 months?
Yes.
Since the chest
It's
infection
increasing now at the
started?
moment. Mm-hmm.
Okay, they are increasing. Okay. Okay, Mr. Adam, can you tell me if you have any headache?
No, no headache at the moment.
Any weakness at any part of your body?
No,
Any abnormal sensation?
no.
Okay. Do you have any skin changes?
Yes, I have skin changes.
What skin change?
Yeah, I have this, if you can see this change in color in my skin.
What color? I
It
can't see. Just tell me it's white color or what?
not white color, it's black patches or more black than my normal skin.
Black patches. At what side of your body?
I can show you here in my hands, in my arms. It's like petechiae and patches like ecchymosis. You can see.
It's black patches in your hands and your arms.
Yeah,
You mean like bruises and it become dark now?
bruises. Yeah.
It was bruises. It was
Mm.
bruises first and then it become dark color.
Yes.
Okay. Do you bleed from any side, like from your nose, or
Yes, I bleed from my nose.
you have bleeding from your nose?
Mm-hmm.
Period also.
Sorry?
For the same period, 6 months.
Yeah, recently increasing. Over the past few months, it's just the infection things. But now I have this bruising and bleeding.
Okay. Any eye changes?
Side eyes, or I didn't get you?
Any eye changes or vision problem?
No vision problem.
Any weight changes?
Yes, I think I lose weight.
How much kg over how long?
I lose around 1 stone over the past 6 months.
Okay. Any weather preferences?
No,
Any lumps or bumps in your body?
no,
Any water work changes?
no,
Any bowel work changes?
no.
Any muscle weakness or muscle pain?
I can't see weakness. It's just tiredness.
Okay. Any joint pain?
No,
Okay. Do you have any past medical history or surgical history of medical importance?
apart from the infections I had, no, I think.
Okay. Do you take any medications right now? Show me a medication list.
No, I'm not in regular medications.
Okay. Do you have any family history of similar condition or any other problems?
No,
Okay. Mr. Adam, do you smoke?
no,
Do you drink alcohol?
no.
What do you do for a living?
Taxi driver.
Ex-driver.
Taxi, yeah.
Okay. How your symptoms impact your job and daily activities?
I always like taking leaves because of this.
Okay. You mean your tiredness is affecting you?
Yes.
Okay. You feel dizzy or tired only?
Sometimes dizzy and most of the time tired.
Okay, we need to stop driving unless we find your problem and solve it. Is it okay with you?
Okay.
Okay. Do you have a partner, Mr. Adam?
Yes, I have a partner.
They have any medical illness?
No,
Okay. Any casual partners?
no.
Did you travel recently?
No,
Okay. Do you use any illicit drugs? Sorry to ask this private question.
no,
Okay. Do you share needles?
no,
Any tattooing?
no,
Okay. You didn't do any procedures or any surgical?
no.
Okay. I'm going to examine you. Is that
Okay.
okay?
Yeah.
Okay, I'll start with the source root.
With
Open your mouth and I want to check for the source root.
yeah, tonsillitis. There is inflamed
Only
tonsils.
tonsillitis.
You can say.
Okay, there is no candidiasis or
No.
no pigmentation in the mucosa.
No. No.
Nothing.
Mm.
Okay, and for the eyes, anything, any pallor, any jaundice.
There is pallor. No
There
jaundice.
is. Okay. The nose, any active nasal bleeding.
Crusted. You can see crusted
Crusted.
bleed.
Okay. For the chest examination, shortness of breath. So if there is any finding in chest examination,
Just clear.
it's clear.
Mm.
Nothing. Okay.
What do you want to find? What you are looking for?
You said there is shortness of breath and there is tachycardia. There is nothing in the chest.
Chest examination, nothing.
Okay, cardiac examination,
Nothing.
nothing. Okay.
What do you want to find? Tell me. I'm looking for this sign.
Okay.
What
Is
are
there
you looking for?
Is it only tachycardia or there's a specific irregularity like AF?
Regular heartbeat.
Regular heart, only tachycardia.
Just tachycardia, yeah.
Okay, abdominal examination.
Mm-hmm. Nothing by inspection.
Any organomegaly?
Splenomegaly, yes, there is.
There is a splenomegaly.
Yeah.
Okay. Okay. No hepatomegaly, no ascites.
Yes, no hepatomegaly, no ascites.
Okay. In the case, if there is any like changes in his maxilla, like or frontal bossing,
2 minutes left.
Sorry?
any changes in the bone, like in maxillary or frontal bossing,
No.
is it his height average for his age or he's shorter than?
Normal for his age.
Okay, no. Okay, what is your concern, Mr. Adam?
What's the problem? Why I'm so ill?
Okay, Mr. Adam, after I talked to you and after I examined you, I think we need to do more tests to answer this question. Okay, from what you told me, you have a low defensive system. Okay, and there is also a low blood count. That's why you have all this tiredness and dizziness because of anemia. And for the patches in your skin due to bruises, this means that you have a low platelet count. That's why you are going. And for your recurrent infections, you have a low white blood count, which is responsible for fighting the bugs. In your case, it's low. That's why you have recurrent infections. So we need to do some blood tests for you to know what is going on. Is it okay with you?
Yes, doctor. So you told me to stop my driving at the moment. If there is any specific things that I need to stop my driving to?
You said that you have dizziness and you can't drive, you have dizziness. Until we find the diagnosis, we need to do some heart rate tracing first. Okay, it's very important in your case.
Mm-hmm. So what you're gonna do to me?
Some blood test and some imaging.
Okay. Okay, so I don't need to be in the hospital.
No, I can book for you an outpatient clinic.
Mm-hmm. Okay. Okay, doctor.
Okay, thank you, Mr. Ray.
Okay, time is up. Examiner questions.
Okay. Can you present your case?
A 24-year-old male come with recurrent infections. Now he is living with sore throat and he had a previous chest infection. And there is signs suggestive of pancytopenia. He has signs of anemia, he has signs of low platelet count, and he has thrombocytopenia, and he has signs of lymphopenia. cytopenia, that's why he has infection. Okay. He doesn't have any positive data suggesting that he has HIV or hypogammaglobulinemia, for example. There is nothing in the chest. There is no bronchiectasis, for example. Nothing.
Abdominal examination?
Nothing. Only the bleeding from the nose and the sore throat and the bruising.
Abdominal examination is splenomegaly.
He has splenomegaly. Okay. So we can find that it's hemolytic anemia, for example. I can put as a differential.
What is the differential diagnosis in this case?
I can put hypersplenism in that case, causing pancytopenia.
Other possibilities?
I didn't find anything in the history or examination.
So how you can manage this patient?
First, I have to do basic blood test for blood count, electrolytes, liver function test, renal function test, electrolytes. Okay, and then I'll go for a blood smear and differential blood count. For splenomegaly, I need to do some imaging. I start with ultrasound to confirm the splenomegaly. And after that, I'll proceed with other investigation.
Okay, so what is the differential diagnosis of splenomegaly in this case?
It could be hemolytic anemia, chronic hemolytic anemia, but I couldn't find any past history. He's 24-year-old. If he has an inherited cause, it could be from young age. So I think
other possibility?
It could be acquired hemolytic anemia.
Okay. Okay. You said you will send this patient home. Okay, so you will not admit this patient to the hospital, or you will admit the patient to the hospital. What is the plan?
I don't know. I don't think that he has red flags. He only has splenomegaly and sore throat.
Okay.
So after the blood test results, we can call him if there is anything that.
So do you want to involve any team in the management plan of this patient?
Okay, infectious disease department.
Thinking of
why he has these recurrent infections.
Okay. Did you examine what other thing you need to examine if you have more time in this patient?
I was thinking if he is HIV or something, there would be lumps and bumps, there would be candida in his mouth.
What do you mean by bumps and lumps? What you examine?
Lymphadenopathy, sorry, lymphadenopathy, lymph node.
So you want to examine the lymph node?
Yes.
Okay.
Okay, there is no history, travel history, sexual history, no tattooing, no needle sharing, no piercing, no tattoos.
Oh, okay. And okay, so you want to examine the lymph node in this case? Okay, thank you. I have no more questions. Is there any time?
Yes, still 1 minute, 10 seconds.
There's 1 minute. Okay. We talk about the management plan. You will not admit the patient to the hospital. Then can you give me the treatment, how you treat this patient?
If he has a hemolytic anemia, I should search for the cause. It could be acquired cause of hemolytic anemia.
What against hemolytic anemia in the history of this patient?
There is no jaundice, for example, and there is no changes in water works or bowel works. And there is no...
so why you are still thinking about hemolytic anemia?
It's acquired. In acquired hemolytic anemia, it could be very acute. And
if the history is acute in this patient?
He has chest infection and he has now sore throat.
Okay. Then which team you will involve the infectious disease? Do you want to involve any other team in the management of this patient?
Yes, hematologist.
Hematologist. Hematologist, you said that there is, so your top differential diagnosis in this gentleman is hemolytic anemia, acquired hemolytic anemia.
Yes,
Given
it could be
the,
acquired.
okay. Can you tell which hemolytic anemia you are talking about? Acquired, example for acquired hemolytic anemia.
Yes, acquired hemolytic anemia could be post-infectious causes. Okay.
How can you the infection, what causing the infection, recurrent infection in this history in this gentleman, given the diagnosis of hemolytic anemia?
He has pancytopenia. It's not only hemolytic anemia. He has pancytopenia, splenomegaly. He is young age. I couldn't find anything that say it's a malignancy. It's only
What
bleeding
kind of malignancy you are looking for?
I'm looking for hematological malignancy, but there is nothing in the mouth. There is no
What sign you are looking for? Can you mention the sign of
gingival hypertrophy in that age to acute myeloid leukemia.
Okay, if it is not acute myeloid leukemia.
And there is no lymph node enlargement.
Did you examine the lymph nodes?
I asked about lumps and bumps, and I said that I want to examine the lymph node.
Okay.
If there is any lymphadenopathy with a splenomegaly?
There is, you can't detect lymphadenopathy, but you have splenomegaly. Did you examine the spleen? Did you know how much the spleen is?
No.
Okay. Okay. Thank you.
Okay.
No more questions.
You excite all of us, Dr. Maida. All of us excited to know what the case.
Okay.
Yes, what is that case?
Okay.
Okay,
So
let's hear it.
let's go. Yeah, let's
Yeah,
go
okay. Here you go.
step by step. What is the positive finding in this case? Patient with recurrent infection. Okay. Patient has a bruises all over. He has a splenomegaly. What do you think?
Hematological malignancy.
Hematological malignancy. Massive splenomegaly. What is the differential diagnosis? She didn't do the splenomegaly, the spleen size, nothing. We have just splenomegaly. What will be
CML.
CML? Yeah, this is CML. Okay, so let's go step by step. You did very well. The only, it's not about reaching the diagnosis, it's about put things together.
Yeah.
How to put the all the puzzle of the scenario together. Young man, the main issue with him is recurrent infection. So the recurrent infection, in my mind, when I enter the station, what I will put in my mind that this patient, as he has recurrent infection, the main cause is low immunity.
Yes.
Think about this, that this is low immunity. Why this patient has low immunity? Low immunity because he has infection like HIV, causing his low immunity. Maybe this patient has cancer, causing his low immunity.
Yes.
Maybe this patient has history of travel somewhere, catching something, I don't know. This is the differential before I take any history from this patient, just from the general look of the scenario.
So you can put Dr. Maida acquired or congenital cause of
Yes.
immunodeficiency. Yeah.
Yes.
Yeah.
In this case, congenital is unlikely because the history just starts for 6 months.
Yes,
And
perfect.
Yeah, and he has no family history, and the patient has no a history of notice before. So most probably this is something acquired for this gentleman. He has fatigue. He has unexplained weight loss. He has 1 stone of weight loss. 1 stone, it means 6 kilo. He has night sweats, was positive. You ask about night sweats, and it was positive. He has a fever. He told you he has 39. His temperature was 39. At the moment, it's 38. So all these signs of infection, deep infection. When I have the case like fever with this 39 fever, I will put in my mind fever of unknown origin. Fever of unknown origin in a patient for 6 months. So I will put all the differential diagnosis of fever of unknown origin in my mind while I am going on with the case. Okay? This patient has fatigue. I'm telling, I have fatigue. I am tired. I have palpitation. This is sign of anemia. So this patient have sign of anemia. With this recurrent infection, I will not let him go home. I will not let him go home. I will keep this patient in the hospital. I will admit the patient to the hospital. I need to know further about his symptoms. I will not. It's not safe to let him go home. Okay. He has easy bruising and he has bleeding. He has recurrent infection. All these signs of a sign of leukemia. Okay. You ask about then what is the positive finding in examination. I know that this patient is bleeding at the moment. I will examine his heart. You ask about the chest. The chest is clear, but he has tachycardia. Did you examine his in heart failure at the moment? Examine complete examination for the heart. Examine the lower limb, because this is what I'm afraid about. This patient have anemia and have now enter in heart failure. This is the complication which I afraid for this patient to have at the moment. Then I will. He has this splenomegaly. Is it dangerous, splenomegaly, or no? I need to find out. Is this spleen? It's very enlarged that it can be traumatic. It can need surgery. So the team I will involve. Definitely hematology. I will involve the infectious disease. Unlikely, because there is no risk to involve the infectious disease in this case. I will involve hematology. I will involve surgery myself, and I admit the patient. This is generally about the case. Then I will let you comment, Dr. Bassem.
Yeah, thank you, Dr. Maya. That's very nice case. Tricky presentation. And I guess Dr. Azza was about to catch the diagnosis. She had the 3 elements of leukemia or pancytopenia, let's assume. So pancytopenia, anemia, leukopenia, thrombocytopenia. You mentioned already the component of leukemia. So you have to put it in your mind. This is what missed only by you. But you did the whole approach while you reached to the manifestation of the positive condition or the disease itself. But you didn't name the disease. You didn't link all manifestation together and name it as a chronic myeloid leukemia, particularly when
But
you have
chronic myeloid leukemia came at this age.
it come in middle age. Yes, it comes in middle age.
How many?
You
It's
can't
25
you can
only?
say
Even
you can say broad differential.
for
Just you can
differential.
mention just hematological malignancy, chronic hemolytic anemia, or infection, and then after that the examiner will go with you why, which kind of hematological malignancy, why not chronic hemolytic anemia, why not infection, and then after that you will justify your differential. But just you can mention broad title
Exactly.
like
Yes.
hemolytic malignancy, hematological malignancy, chronic anemia, infection, like this. No
Yeah.
need to just to mention the diagnosis. Not a matter of a diagnosis.
Yeah, I'm talking about the topic itself as a differential, of course, but on the top of differential, whenever you have huge splenomegaly associated with pancytopenia, with the chronic course, you have to suspect chronic myeloid leukemia. Yeah, the age is not that much common. It's commonly at the middle age, 40s, 50s. You're right, Dr. Aisha, but still, you can say as a differential, and I can think about other cause of pancytopenia or hematological malignancy. As acute myeloid, it's not the course of acute myeloid. It's not, of course, chronic lymphocytic leukemia, which comes in elderly age. So I have only chronic myeloid leukemia or hematological
Because I
malignancy.
think the chronic myeloid leukemia always in old age. This is what I
Not
think.
old, in the middle age.
Not always in old
Yeah.
age. Data by
It is above 60, يعني, not
No,
young. Right?
not 60.
by model age
Not
distribution for
60?
AML.
Maybe,
The above
yeah.
60 chronic lymphocytic leukemia, كلل above 60 and elderly age. But chronic myeloid leukemia, as Dr. Muhammad mentioned, it's coming as either middle age, sometimes it comes the early age. Anyway, you have the positive finding, Dr. Aisha, for the chronic myeloid leukemia, right? Huge splenomegaly, I think it give you the clue. This is the case. We're not talking about classic case and classic presentation in the exam, but we are thinking widely how to put differential and why to put this differential, okay? This is the way how to think about and to link about all this manifestation together. Low immunity in this age, supposed to ask first question, as Dr. Azza asked, uh, was this started recently or previously? So you can ask, is it since childhood? If you have since childhood, you have to suspect the congenital cause, immune deficiency syndrome, whatever the name. They will not care about the name of the disease, but you have to know at least one of them. But to name it as congenital immunodeficiency syndrome, you have to put it in the differential, particularly if the patient have these infections or recurrent infections since childhood. Against this scenario, the patient is having the infection recently, 6 months ago, and he has other component of low blood count, I mean low white blood cells in the form of infections, low hemoglobin in the form of anemia, and the manifestation of anemia, of course, and the low platelet in the form of petechiae or ecchymosis, or even bleeding tendency. I prefer Dr. Azza to admit this patient for the dizziness. You have symptomatic anemic patients. Dizziness. You ask and you address the driving by the dizziness. How you will not admit this patient if he has dizziness and you stop his driving because of the dizziness? Dizziness, one of the positive symptomatic anemia features you have to admit any patient for. Definitely, this patient will have hemoglobin less than 7, right, Dr. Azza?
Yes,
So you
Dr. Bert. Yes, I'm here.
yeah, you address it in the wrong place. You address the dizziness for the driving, but you didn't address
Yes,
it for the admission, which is important this scenario.
yes, I
Like,
totally agree. Yes.
yeah, so dizziness for any reason should be admitted. Why? If you leave this patient go home, he might have dizziness, he will faint or blackout, fall down, head injury. It's against the welfare, and legally you will be in trouble. These are the common complaints that need to be admitted, the dizziness or the fainting. For differential, I have to admit till I will have a diagnosis. Otherwise, Dr. Azza did the examination. I think you jumped to the chest and examination of the neck, but you didn't examine the hand. Yeah, I agree to examine the hand, the pulse character, pulse volume, regularity. You ask it later, but you start with this. General look is very important. Whenever you start to examine the patient, you start at the end of the bed. How will the patient look? You have to ask this question to yourself. And in the exam, of course, you have to comment on why this patient definitely he's cachectic or underweight. He lost 6 kilograms in 6 months. I think he might be underweight because of also recurrent infection. He might be also looks sick or toxic. You will see him and you can comment on this. Then proceed holding his hand, examine the hand. From the hand upward, examine the other system, but don't skip examining the hand, as a vital chart also is there, pulse oximeter, pulse rate, blood pressure, and temperature. You can ask this question initially, then proceed further to the eye or whatever you want to examine, but you have to start with the hand. Otherwise, I think you cover most of the questions in the history taking. And you put differential, but the case diagnosis, it wasn't in your mind. You suspect something related to infectious, which is not the case, but it's one of the differential. You have to put the differential of infectious cause. HIV or any virus infection might lead to pancytopenia. Dengue fever, even dengue fever, it might be there, but you have to ask the question for dengue fever, for example.
Thank
Any
you, Dr.
insect
Wilson.
bites. Sorry?
Yes, mosquito bites
Exactly,
and
yeah. Any bite, any also travel.
it's
You
not
ask,
pancytopenia. I think it's leukopenia and thrombocytopenia, but the red cells will be normal.
yeah,
And then,
And
yes.
it will be acute course. I need to know the differential for this case.
uh,
The differential
yeah.
diagnosis will be after chronic myeloid.
I think it's infectious, chronic infectious like cytomegalovirus. One of the viruses can cause pancytopenia. I think also parvovirus,
But for 6 months is also, it is long history.
HIV.
We need chronic cause. Yeah.
I think HIV one of the
Like for
chronic. Yeah,
differential diagnosis, I will put the differential of all pancytopenia. In this case, it's not pancytopenia per se, because white blood cell I suspect will be high in this case. But I will put the differential diagnosis of pancytopenia. In this case, like aplastic anemia.
exactly.
I will put myeloproliferative. It's unlikely in this case. Because of the age, but I will ask about infection, viral sepsis, tuberculosis as well. TB can be, if disseminated, can appear like this. Also, if she's a female, I will suspect even SLE can come with
Aplastic anemia.
aplastic anemia, and she has drugs, medications. This is also
Exactly.
differential
Yes.
diagnosis of this case. And put in mind that this patient has fever. So fever for 6 months, this is fever of unknown origin. So you will put all the differential diagnosis of the fever of unknown origin can be in this case. So you need to go through it. It will be infection, malignancy mainly. Infection and malignancy mainly, and
Yes.
pathological disorder is in the top of the list.
Yeah, I think also as Dr. Maida mentioned, any drug causing bone marrow suppression, one of the possibility here. However, patient is not taking any medication, but we
The
put in
problem
mind.
is a long history. Also, aplastic anemia will not let the patient live with here with these 6 months.
You will see when you put your differential diagnosis will be against. I will put.
Okay, yes. It can be like toxin, maybe proceed.
Yeah.
Something will be long exposure.
I will say like that. That's why important the work is the work history, where he work and all these things. But again, is that
So it can be HIV and other differential HIV. Yeah.
I put all the differential in my mind, and then according what it is, then you play your card.
Yes. Thank you, Dr. Maida. It's nice case. Infectious day, right? We have the bloody diarrhea, inflammatory bowel, and now we have infectious as fever and recurrent infection. Although the bloody diarrhea was an inflammatory bowel disease, but still you can suspect also associated infection or cancer. Anyway, it's nice topic. Both of them are nice topic. Covered well by Dr. Maida and Dr. Azza. Any question, Dr. Azza, about your performance or about the topic itself? You want to ask anything?
Thank you, Dr. Basim, for all your comments. Thank you.
Yeah. Always take the positive thing from any comment. How to do, and I learn a lesson today. I learned this case. Imagine still now, and since long time we started these sessions, the topic still we have new topics every day. We discover case. Chronic myeloid leukemia. I think we didn't practice it before as a case in long consultation scenario, but it might come as low immunity, yes, or abdominal discomfort. It's important also presentation of chronic myeloid leukemia, along with the anemia or other manifestation of anemia. So yeah, all topics can be uh, repeated with different complaint or different presentation. So we are learning as usual from all of you. Thank you for the cases, for the participation today. Thank you, Dr. Azza, Dr. Maida. Any question from you, Dr. Azza and Dr. Maida? Okay. From others, any question, any comment? Dr. Aisha, do you want to add any suggestion?
No,
Dr. Muhammad?
interesting cases today, really.
Yeah.
Both interesting,
Yeah.
yeah.
Dr. Muhammad Omar, you want to add any comment? I notice you're active today.
No, thank you, Dr. Basim.
Okay.
Nothing from my side.
Yeah, thank you also for your comments, your chats, comments. I hope, I think there is some comments I didn't read. Yeah, malaria, I wrote it myself because of huge splenomegaly. It can also be present with plastic anemia, but against malaria, no travel history, for example. And let's go up more. Yes, dizziness. I wrote dizziness for the admission. That's why. History of steroid, particularly when you ask about any drug history, you can specify the history of steroid itself, because easy bruises and chest infection, recurrent infection because of also neutropenia, one of the presentation or possible presentation of steroid or cushingoid patient. But it's not the case. However, you can ask this question. Chronic myeloid leukemia, yes, it need about the case. Need admission, yes, for further workup. I agree. Missed hand examination, transfusion history is important. If you want to rule out hemolytic anemia, you have to ask about transfusion, Dr. Azza. I wrote these comments because I know sometimes I missed during comment. Maybe Dr. Ahmed, yes, I don't know what is IEC. Dr. Ahmed, you can explain what is the IEC you wrote? Aplastic anemia, parvovirus, chronic myeloid leukemia, bimodal age, yes, I agree. Dr. Hassan, can you get chronic myeloid leukemia in your 20s? However, all age groups can be affected by chronic myeloid leukemia. This answer for Dr. Aisha. And there is a small but insignificant group of patients diagnosed with chronic myeloid leukemia at a much younger age, including some diagnosed at 15 to 29. Oh my God. A group frequently referred to as adolescent and young adult.
But it's really rare, يعني.
Yeah,
For
it's not
common,
critical.
the common is the old, yes, the middle, or يعني,
Exactly.
not as
Middle
common in
age.
young, yes.
Yeah,
Yes.
if we can put in this age or younger, little bit, 15, 20, you can say acute lymphoblastic leukemia. This is what I remember also, but it comes in the children more. But still,
Yes,
15
the children have the acute forms of leukemia more, and the
lymphoblastic. Yeah.
adolescents, but yes, and the young age. But the all, as you give longer, you or older, you will have the chronic form.
Yes, exactly. Correct, mind leukemia. Okay, anyone search about IEC or Dr. Ahmed himself? I don't know, where is he? IEC, iron. I don't know. Dr. Aisha, if you can search about IEC quickly. IEC.
What is
Any question?
IEC? What?
Yeah, IEC medical abbreviation. I will search. Wait. Any question from others?
IEC?
IEC. I'm researching as well. IEC medical abbreviation. Initial episode of care? No, it's not. Immune effector cells? I don't think also. Okay. Maybe something mistakenly written. Infectious endocarditis. Okay. Bad. Infective endocarditis. Really? It's no, I think IE only. Infective endocarditis. No need for C. IE as infective endocarditis. Endocarditis, yes. Okay, okay. All of you wrote it, infective endocarditis, but I don't think it's abbreviated as IEC. It's IE only, infective endocarditis. No need for C. This is what I know. But anyway, as a cause, splenomegaly, anemia, maybe as a spreading infection, you can suspect it, but you have to have the finding risk factor of infective endocarditis, sharing needles or recreational drugs, HIV, murmurs on the examination of the heart. But still, yeah, infectious, yes, it is infectious. Still as infectious. Infectious
Infectious endocarditis, I like it.
Yeah.
Really important differential diagnosis.
Yeah, because there is fever, night sweats.
Mhm.
Yes, you have the same finding. It might be also complicated with plus anemia and thrombocytopenia as splenomegaly. Yeah, indirect way. Anyway, thank you for this differential. Again, thank you, Dr. Maida, Dr. Azza. Thank you, everyone attended today. Any question before ending the session? No, we can end. Waiting for you in the communication tomorrow. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.